if you hold the radial neck and then try to pull it longitudinally and see along with the ulna if there is any difference in the movement. Suppose if there is a movement, then you will have to check the inferior radioulnar joint as well, and then you have to correctly diagnose it and then make it all right. So now there is the same patient which I was focusing, and you can see that once you do all the procedures done in a right distinct systematic manner, you get a good movement, and then they get an excellent outcome. What is important is understanding, diagnosis, and then the correct sequence of approach if you do. And then the key element is get your ulnohumeral joint nicely reduced, congruent reduction. That is what is important. Of course, the approaches are there, lateral and the medial approach. The lateral approach, I'm sure all of you know, the common is the Cocker's approach. But often what happens is, often you do a EDC split approach, but often there is a rent. Already the injury has produced a rent. And then you can use that rent as an approach and then get your way along and then get the fixations done. On the medial side, commonly used is through the ulnar nerve split approach, ulnar flexor carpi ulnaris split you can use, and then go on to the anterior side and then fix it off. So the methods by which you fix is the coronoid is the one that you start, and you know the classification is the Regan-Morris classification that generally is. So type 1 is you use either a suture anchor that you can use. Anteriorly, you can go down and put a suture anchor. Or also you can put like a lasso technique, you can bring it out and then use a endo button, or you can also make 2 holes and then tie it up with this. So there are many methods like that you can use. Whereas, so this is one of the patients, you can see that it has been reduced, and then the endo button has been used. And then you see the final result, you can see they all get a very good result. So perfect, phenomenally good result you get. Only thing you need to do is to follow the protocols, and then if you get it done, there is no issue at all. So the Regan, suppose type 2, if you get, again, you can do the same. If the bone chunk is slightly bigger, you can use the screw. Screw fixation also is a possibility. And then you can, once you do that, then again, only thing is whether you use the sutures, anchors, or the screw. Suppose if it is a very basal fracture, and then if it's a wide fracture, then you can also use a plate. And then when they use, and if you have followed the correct routine, all of them go on to have a very good result. So what is important is once you manage the coronoid, then you go on to the radial head management. The radial head management, you are looking at either a fixation or a replacement. There is no question of excision, especially when there is an instability is there. Forget about excision. So if you excise it, it becomes completely an unstable joint. They will end up with a very poor result. So you are left only with 2 options like fixation and replacement. So the restoration of the radiocapitular coaptation is very important. That is the key aspect of elbow in fixations. So here you can see this is a patient, 39-year-old, who fell from bike. They present after a week of time, and then you can see there is a flake of coronoid, and also the radial head is broken over there. And then what we intraoperatively we were not able to fix it, so we can take it out and then nicely reduce it and then fix it back to position. What is important is where exactly you put the plate on. Plate on is like you need to put it on the safe zones. So often when you take it out, there may be a possibility or a confusion as to where exactly you put the plate. It is easy to see if you see the surface, that is the side surface, the articular margin. Wherever the articular margin is the narrowest, that is the area you will put the plate. So that will help you to put it. And also when you are putting it back to position, follow the Lister's tubercle. Your plate direction must be towards the Lister tubercle. If you follow that, generally you are all right. And also here again you see this plate fixation that has been done. So at 9 months you can see they get a very good movement here. And this is a safe zone that I was explaining to you. Suppose if you are keeping it in neutral position, in the neutral you can see that the tangential is drawn here. Anterior to it is 65 degrees and posterior to it is 45 degrees. That from the supination to pronation. And in this angle, that is around 110 to 120 degree angle, that is also the area where you have less of an articular margin. And then you can also put a plate over there. And that is the arc of, that is the safe zone that you always have to remember to put your plate on. This is a 29-year-old. You can see here is the fixation. There is a fracture here, and also it is comminuted. You can see the comminution is more on the posterior side. So when it is more on the posterior side, you will have to think, suppose you can't put a plate all around here. So plate maybe is coming somewhere in this portion, the plate will be coming. So here is to fix this fragment. You can use a tripod type of screw fixation, like you can go from here and hold it onto the shaft. And also here you see this is the rent here, and then that is the fragment that is on the medial side. So when they were doing a 3D, it has been taken off. So this is the fragment that is there. So you know that you'll have to go through the two approaches, and then this is the fixation that we do, and then you can see that this is in situ, there it's fixed. And then what we are doing is, when we fix it here, once this is the screw, whenever there is a portion of the articular cartilage where you need to go through, which is bigger, where you cannot put a plate, it is always good to you go through like this. You can use either pins also you can use, and this is the Herbert screw that we have used. It goes from the top of this cartilage and then ends onto the shaft here. And you can use 3 screws without the plate also. You can use 3 screws. That also has given a good outcome. And here you can see when we are looking, once the radial head is fixed, when we were doing a valgus stress, you can see there is an opening on the medial side. So you know that because of that small fragment that is broken, it is giving you the valgus instability. Valgus instability. And then that's, hello? Sibin, you are able to hear?
Yeah.
Yes, sir, you can continue.
Yeah. So you can see that there is a valgus instability, and then you can, once it is sorted out by medial approach, and then you go and repair the anterior band of the ulnar collateral ligament, you can see that nicely the joint gets congruently placed. And this is the final outcome he gets. You can see that entire flexion, extension, supination, pronation, everything gets retained. Elbow is completely stable. And once you know that all this can be done nicely, the radial head fracture, if it is so more than 3 fragments, suppose if it is more than 3 fragments, then you may have to think of a radial head replacement. Still you can try to fix it, but often you will end up doing a radial head replacement. So this is a patient who had multiple fractures. You can, though this is a big fragment, but the portion that is here on the multiply comminuted, we are not able to reconstruct it. So this ends up with having a monoblock stainless steel type of radial head replacement. And then once you do it, what is important is the length. Suppose you get the correct length and then you get the radio-humeral ulnar joint correctly, congruently placed, then for sure you are going to get a very good movement. The functional outcome will be extremely good. So the radial head arthroplasty, if you take, what decides your arthroplasty is that comminuted fractures involving the whole head, so where you cannot get a satisfactory reduction, so you have to think of replacement. Or if there is a partial head fractures with more than 30% of articular margin, where radial head again cannot be reconstructed. And then fractures with more than 3 fragments. These are the basic rules by which you will have to think of a radial head arthroplasty. Once you figure out whether you have fixed or replaced the radial head, then you will have to fix the lateral ulnar collateral ligament. So you can isometrically, the middle of your capitulum forms the isometric point. You can put an anchor over there, or you can also make a tunnel. You can put a transosseous tunnel and get a fiber wire and stitch the lateral collateral ligament. Many times the lateral collateral ligament, you see when you are holding it, try to hold posterior to the radial head. when you are trying to hold the posterior, a lot of the times you may not be able to see it, but generally you can figure it out. And then it must be able to hold the ulna. So once you are holding the ulna and then try to repair it to the lateral condyle, it will be easily placed, and then you repair it. So should be an all right. And then again, once all the things are done, if it is stable enough, then there is no need to go on to the medial side. If it is unstable with the 30 degree of extension, then you will have to open on the medial side, and then medial collateral ligament, you will have to repair it. Sometimes, even when you do the medial collateral ligament, there may be a post-row medial instability that still happens. That happens because of the posterior band that is of the medial collateral ligament that is not being secured well. It might happen. So in those instances, you will have to put a hinged elbow external fixator. So that is the protocol that has to be followed. And if you follow that, there is no problem at all. So based on the intraoperative stability that you have got during the surgery, you can start moving the, immediately after second day, you can, once the drain is out, you can start moving the elbow joint. Around 4 weeks time, you might think of getting a complete extension with good forearm rotation. And then after 8 weeks, you start resistive exercises. That is the protocol that we follow here. And one of the concepts that has come out is you should never forget that when there is the concept of, that is the O'Driscoll who has classified it, and then posteromedial rotatory instability. This is the pronated and varus position. When there is an axial load, you can get it. And more often it is the radial head may be intact. And then the majority and coronoid will be broken on the medial side. And this you need to think it is also a part of a terrible triad and then fix it. The other part is the transolecranon type of fractures with coronoid, and then the radial head. Sometimes they can also have, and then you will have to think of a fixation. Some of the X-rays also was put up by Roger Van Riet. He also has explained about it. So all those you will have to see. A part of it is like posterolateral instability, and this is the posteromedial rotatory instability, and the other one is the transolecranon type of dislocations. All these you will have to think of managing it very well. This is the O'Driscoll's concept of the medial facet, and that is you will have to approach it through the medial side and fix it. And once you approach it from medial, because fixation of the medial anteromedial segment is very important, because there are instances where early arthritis can take place, and then stiffness or the pain will be very quickly seen in these patients if you are not managed it. And also there are chondrolysis has also been reported in anteromedial facet fracture dislocation. So I think anteromedial, you must give a constantly, you must look for that and then get it corrected well. So now, if you ask me, like, having said all these things, is there a role for a non-operative management? So there is a paper by Matthew et al. Who said if there is a minimal or an undisplaced fracture, there is no mechanical block to movement of elbow and forearm rotation, concentrically reduced ulnohumeral and radiocapitular joint, and stable arc of motion up to 30 degree of extension. If all these criteria is there, still you can think of going ahead with conservative management. However, Shukla et al. Has said that radial head fractures, even if it is depressed by 2 millimeters or angulated by 30 degrees, there can be 80% chance of loss of the concavity compression stability of the radiocapitular joint. So that is why it is important to say that you cannot take anything granted, but it is always preferable to go ahead and operate all these terrible triad injuries. So in summary, CT imaging improves understanding and helps in planning. Restoration of the ulnohumeral joint is the key. That is the standard. The radial head is important secondary stabilizer. It must be either fixed or replaced. Lateral collateral to be repaired in all cases. MCL repair or a hinged external fixator depending upon the stability you have got. And if elbow subluxate within 45 degree, you must revise the fixation. Thank you very much.
Thank you, Dr. Devandayalan. That was a very difficult topic which I have extensively covered. I know it is very, very difficult, and you can only do that. So one quick question from me. So you said that about the radial pull test, and once you have fixed the radius, you pull it and then find out.
No. Before you fix the radius, before you fix the radius. You can do it before you fix the radius. You can try to pull it when you have removed the radial head. When you have removed the radial head, then only you can pull it and see against your ulnar segment. Suppose if you have fixed it, you can't pull it. You will have to take distal X-ray and you have to analyze.
So if there is an SX low-prosty lesion, then what will you do if it is only a distal radial ulnar joint instability? Will you just wire it, or how do you maintain it?
No, in one of the cases, actually first case that I showed, they also had SX low-prosty. But you see, in that fracture, what we went was initially we fixed the distal radius first. So once I fix the distal radius, I know that distal radius is aligned very well, and then I come back and fix the radial head. So now I know that I got the length. The situation comes only when you are replacing the radial head. When you are replacing it, sometimes you might go err on whether it is a smaller prosthesis or a bigger. In our setup, we don't have a modular prosthesis. We have a fixed, solid, monoblock, stainless steel type of a prosthesis. In this prosthesis, very difficult to adjust. So sometimes you may have to add bone cement and then get the length all right. So you'll have to make some sort of adjustment. Till we get the modular prosthesis, we may have to do some adjustments like that. But getting the radial length is the key. You will have to get the correct length. Of course, lot of techniques are there. You can see, like, moment you put the radial head, you'll have to make sure that it is correctly. Lesser sigmoid notch must match. Topmost portion of the radial prosthesis must match the topmost area of your lesser sigmoid notch. And then when you have put it, you can also do the fluoro and see the humero-ulnar distance on the medial and the lateral side. It should be congruently placed. It should not be overstuffed, or stretching of the lateral side should not be there. So these are the points by which you can check it out. So,
sir, one question. Yeah. Sir, you have shown the fixation of chip fractures of the coronoid with the radial head. Suppose there is a slice fracture of the radial head, and how do you approach the coronoid? Do you go through the middle part, or is there another way? You can't take out the whole radial head. So if it is a slice fracture, only one part, type 2 Mason, something like that, then how do you fix it?
Oh, see, like when we are not taking out the radial head also, see these fragments that are there, those which have been anteriorly coronal slice has come off, they are just staying away from you. Before you reduce it, you can approach the olecranon and see. So majority of the times, it is anterolateral corner of the coronoid. So one moment you go through it, you can see it through. Suppose if you are not able to see, don't hesitate to go onto the medial side. You can do the over the top approach or even the other approach and then get it done. So you should not hesitate. You must. Fixation is the key. I think Von Rate can explain it also, because he has done a lot of work on the elbow. So
I wanted to first of all congratulate you with the talk, because that was an excellent overview of all the things that you need to know before you treat these patients. Because if you don't know the biomechanics and you don't know the basis behind it, there's no way you can have a good result. And then you need to know all the approaches, and then you need to know plan B and plan C and plan D. I totally agree with you. What we do when we have a small coronoid fracture and a radial head fracture is my approach becomes a little bit bigger. I try to do it from a lateral side. I try to avoid the medial side because of stiffness again. But what you do is you go on the lateral side. I do an extensor tendon split. I don't use coccus interval, but extensor tendon split. And then it's very easy to just slide up the humerus, release. If it hasn't been torn yet, you can release the capsule, put a big retractor in, and then you can see the medial side and you can see the coronoid process. And obviously do this before you do the radial head, because you don't want to destroy your fixation. And then you can either put a screw in from the lateral side, which sometimes is difficult, or you can do a lasso technique with a suture like was described by Dr. Mori. And basically, you're not treating the fracture as such, but you're just pulling down the anterior capsule onto the coronoid process, and that sort of heals without problems. And it greatly improves the the stability of the elbow afterwards. One thing that I want to add is something that I personally really enjoy doing is doing it arthroscopically. And so you go in with your camera either at the beginning of the case, but that's difficult because the elbow might swell, or just from your lateral portal, from your lateral from the lateral side, you put your camera in, and you can actually see all around the coronoid process, and you can see a reduction. That's really fun to do. It offers me more in view and more in knowledge than fluoroscopy. So I tend to avoid fluoroscopy if I can, because it's sort of, sometimes you can feel very happy on fluoroscopy and it doesn't look that good afterwards. Whereas arthroscopically, there's no hiding. It's good or it's bad. You can't hide behind your scope.
One more thing. Yes, sir, one thing. The Wrightington school says that you need not fix that small chip fragment if you are stabilizing the radial side. So what's your take on that?
No, very often you don't need to fix it. If if you feel that you have a nice big chunky radial head fracture and a very small chip fracture on your coronoid, Dr. Morris showed that type 1 fractures do not need to be fixed. O'Driscoll made that a little bit more complex as often, because he showed us that some of those chip fractures might be anteromedial facet type fractures, like was shown in the previous presentation. And if you miss those, that's bad. If you miss a chip fracture, or what some people call avulsion fracture, although it's not really an avulsion fracture, that's no big deal. That's probably not a problem. But it's those fractures between type 1, more type 1 and type 2, where you think, maybe I can leave it, maybe not. Those fractures I like to use the lasso technique.
Sabine, actually, if you see, like when there is a chip fracture, suppose if it has to come dislocated like this, you will see that a lot of anterior capsule is avulsed off completely. So it will not give any support. So I think it is better to fix it. And also one of the other point I have to make is, like, if you take a Cocker's approach, you are coming from posterior to anterior. So many times you may find it difficult to retract and see through. On the contrary, if you go through the EDC split, that is extensor digitorum communis split approach, you are more anterior. Your fracture is also anterior, and you will also get the good approach to the coronoid. Sir,
yeah, one question from the delegates. What are the tips to avoid posterior intrusion of palsy during plating of the radial nerve?
No, I didn't touch upon it purely because I thought it would take time. But you see, like generally from the lateral condyle, suppose if from the lateral condyle to the radial nerve around 5 centimeters, or if you take from the top of the radial head up to the radial nerve area, it is 4 centimeters. You will have to be careful. So if you are do it, it's okay. But suppose if you are going through the Cocker's approach or a EDC split, if you stay within this, it is good. Whereas if your entry is little anterior and if you are going like a Kaplan approach, then you will definitely end up seeing the radial nerve. So even otherwise, if your dissection skills are good enough, there should not be any problem. And also keep it in pronation. When you are keeping it in pronation, you will try to stay away from the radial nerve. But keep in mind about the 4 centimeter distance, and also make sure that you are keeping it in pronation. Then you are generally safe in these approaches. One you can also add. So Roger,
stay on the bone. Stay on the bone when you're dissecting to the neck. I'm fishing for an invitation for next year, but I love to do low profile fixation. So I don't use plates. Generally, don't use plates. And do the you mentioned it during your talk where you have some extra fragments and you put a diagonal screw in. Yeah. I tend not to use plates and do I think Dr. Mori called it tripod fixation.
Tripod fixation.
And so I try to avoid plates, and then you avoid the radial nerve obviously immediately.
So those are headless screws or small fragment screws? Is it headless
screws? Headless screws.
Yeah, same here. But there's nothing wrong with small fragment screws. But you have to bury them under the surface. So if they're not buried, they become a problem because they can back out. They can protrude a little bit. And maybe I missed it, but I always suture the annular ligament at the end of the case. I always suture it because it's an integral part of the LCL complex. And if you cut the annular ligament on lateral or posterior, it doesn't really matter. If you cut the lateral ligament, you will lose stability on the outside, on the lateral side. And so I always suture it. And I also think it acts like a brace. It acts like a brace to support your fracture fixation. So that's something that I always do.
So one more question is there from the delegates. Is there any anterior approach for coronoid?
Yes, over the top Hotchkiss approach is the anterior approach. So
okay. So
well, there is a full anterior approach as well that you can use for coronoid or capitellar fracture. And I remember this is a bit of internal kitchen in our hospital. Was my vacation, and our hand surgeon, who's a very, very good surgeon, well, a fracture came in and he said, "Wow, I fixed it through an anterior approach. It was excellent. I could see everything." He was very, very happy. And 3 months later or 6 months later, I ended up doing an arthrolysis because it was so stiff. So
that's the main issue. I think the questions, there are no more questions in the chat box.
We can go with, sorry, Sabina, a lot of time. Can we go with a single case presentation from Professor Sundar Vadivel? So any one good case of yours? In the meantime, sir, really, sir, in India, we don't have a good coronoid plates. And so how do you manage such big, huge coronoid fractures when you don't have?
I use some facial-maxillary set plates.
But the screws are only 16 mm. They're not long enough.
Oh, that is sufficient. So I don't see any reason for. Suppose when there is a one screw, you can put like a 3.5 screw system, but the remaining you can also use these plates. They're flexible plates, and then multiple shapes are there. You can use any of them. So.
Yeah,
Zimmer has a small fragment screws, I think, available. Small fragment set of Zimmer has long screws also. It's malleable.
Those are expensive. I mean,
yeah, it's expensive. Yeah, Professor Roger, you want to say something?
No, you can use finger plates as well. Little T plates have been used in the past, and you don't need to use anatomical plates. I agree, they're very expensive. They're sometimes difficult to use, and I found that even in anatomical plates, I end up bending them anyway. So you can use whatever you want. And if it's a very big fragment, just use only screws instead of a plate.
Professor Sundar Vadivel, you want to share your case? Anyone good case? Yeah, please share your screen.
Yeah. I'll start sharing. So. You're able to see my screen?
Yes.
Yeah. So at the outset, I wish to thank the intense session which has been going on, and thank the OASIS TRAUMACON entire team for so far having good session. So let me share some. I thought I'll share two cases. So depending upon. So the panelists, Professor Amarnath Surat and Dr. Subin. So we have been discussing about a lot of complicated cases. I thought that we'll see what are the things which you can see in the X-ray. So can we have for the younger elbow surgeons? So what are the things we look in the X-ray? So any of the panelists would like to take?
Yeah. So it's an elbow AP and lateral view. So in the AP view, you can find there is a radial head fracture, and there is double shadow around the capitulum. On the lateral view, looks like there is a capitulum fracture, radial head fracture, elbow is subluxated, and coronoid, there is a doubtful coronoid fracture. So going for a terrible try, something like that. More than terrible try.
There is also, it is capitulum also is broken, and also trochlea also is impacted. So I think so.
Trochlea, yeah.
Yeah, so the double arc which they are mentioning in the AP view is the capitulum, because this double shadow which says, but the trochlea is also not normal. We can see that there is a step off, and this is a double arc sign which has been described. So if there is a double arc which we are seeing, then it means that in addition to the capitulum, there is also a trochlea fracture. Yeah, so it is more of a partial articular fracture. So these are the CT images. So how would you like to approach this fracture? And what are the implants you would like to have? So the approach for this fracture, and what are the implants you would like to have? So the panelists.
Maybe I can take this. So, I would use a combined medial and lateral approach for this. It needs to be reduced perfectly, and I use headless screws if I can from anterior to posterior to fix this distal humerus fracture. If it's an elderly person, then for me, my threshold to go to a hemiprosthesis or prosthesis would be low. But in this case, with a younger person, I would definitely try to fix it. And then the radial head separately with the radial, just with the same headless screws.
So you'd like to approach both medially and laterally, or you'd like to first see the lateral approach, EDC split or the capillary?
I will always start on the lateral side and see how far I can get. But in this case, because in a normal capital shear fracture where you have one big piece and you reduce it, that's easy. But this piece is also broken in two, and then the medial trochlear also fractured. So I would definitely, well, let's say 99% sure I would go medial and lateral with two separate incisions. In the beginning of my career, I was trained partly by Greg Bain from Australia, and he always used the posterior incision to do that. So in the beginning of my career, I always used posterior incision, big medial flaps, big lateral flaps. But gradually I've gone to two separate incisions and had less problems with soft tissue swelling.
So any other difference of opinion? Then you want to?
No, it is the same, like lateral approach. I will go and then see.
Yeah.
But because, as he said, the trochlear management might become difficult. So you may have to open on the medial side because it's an impacted fracture. When you are bringing it out, the positioning becomes a little difficult. So you'll have to see it clearly. So I think medial approach also may be needed, or direct anterior approach also sometimes is very useful in this.
As that Ray was telling that it might produce more stiffness. So I just went through the lateral approach. So it is a partial articular capillary and trochlear shear fracture. The approach and the implants, it is mostly only the headless screws which we need to keep. So I just went through the EDC split, and from lateral approach I did not go medially, but I could get the trochlea right, and then I could fix the capitulum also. Capitulum was comminuted, so I had to use a lot of screws, but I could get the joint congruous. And so the take home will be analyze the fracture lines, fragments. You should plan for your exposure. So if lateral approach, we are not able to expose the fragment and get adequate reduction, we must be prepared for the medial approach also. And because so many of us will not be endowed with all the implants off the shelf. So you may have to order everything. So just some plates and few of the screws may not be enough. So you have to have the entire armamentarium to address this fractures. So if there is time, just one more, is it possible? Just to discuss one more case? Or will it close?
Okay. I think we are out of time, so I think go through fast. It's okay.
Yeah, I'll go through. This is just a non-union. I just want to say, because I'll not ask for the opinion, I'll just finish off. So the issues are the small distal fragment, osteoporosis, and the joint stiffness is one which the younger colleagues must understand. So the movement is taking place at the pseudoarthrosis, and we must get a good range of movement. So otherwise, if you just fix that, then we might end up with the joint becoming very stiff. So the principles of management will be the clearance of the soft tissue. You have to adequately clear and mobilization of the distal fragment before we go in for a fixation. So the ortholysis is very important. That is the ulnar posterior approach. So ortholysis is important, and compression at the non-union site. Of course, like any other non-union. The metaphyseal non-union, you have to mobilize the distal fragment for a stable fixation. So this is the fixation what you can get. And if the distal fragment is very small, then we can go ahead with the modification of the fixation like a double tension band. So thank you so much for the opportunity once again for the organizers. Thank you.
Thank you, sir.
Thank you so much. Now I ask Anil Kuti to do the closing remarks.
Okay, anyway, we had a great session this evening, and I would like to thank, first of all, the president of OASIS for being here, and I'm not taking much of time. The foreign faculty was excellent. I'm of Mackey and Van Wright professors. Thank you all, and also the national faculty. You have done justice to, and a lot of people are logged in. 225 people were there, and most of them are still there. So excellent session, and I would thank the Karnataka team, the Bangalore team by Mallikarjun sir. Thank you for taking up this job very late. Within a month, you could organize such a great program. And thank you all. And thank you all delegates for logging in. Thank you all.
I think you should thank our young tech, Dr. Vamshi has put his lot of his effort behind the scene and front everywhere. And thank for the opportunity given to us by our KOA team and Dr. Nityananda Rao, our Vice President, and KOA President, Dr. Chandrasekhar, and OASIS team also. Once again, I thank all the overseas faculty and our national faculty. And all. Good night. Thank you. We'll meet some other time in some other occasions.
Yes.
Thank you very much.
We'll have an OASIS ICL also in July last, maybe 25th of July. All please join us again. Thank you.
Thank you, Karnataka team. Excellent show. Thank you very much.
Thank you, sir.
Sir, Nityananda Rao, sir, you want to add on anything?
Nothing, fine.
Thank you all.
Thank you, sir.
Good night.
Thank you.
Thank you. Good night.